Dear students, in this video, I will explain silolithiasis, which refers to the formation of stones in the salivary gland, commonly in the submandibular gland. Patients between the ages of 30 and 60 with silolithiasis typically experience cyclical postprandial swelling of the major salivary glands and dryness, possibly due to decreased salivary flow. Duct abnormality, inflammation, and increased calcium content of the saliva may contribute to an increased risk of silolithiasis. Chronic dehydration and pharmacological causes of decreased salivary flow are often linked to this condition. The submandibular gland is most commonly affected, accounting for 85% of cases, due to the ascending course of its duct, which predisposes it to stagnation of the mucinous as well as the more viscous saliva it produces. The alkaline saliva precipitates calcium and phosphate and predisposes to stone formation. On examination, there is an asymmetrical enlargement of the gland, and in certain cases, a large proximal stone may be palpated. Submandibular gland duct stones are mainly proximal, and parotid gland duct stones are mainly distal. Silolithiasis complicated by a secondary bacterial infection may present with an abscess. Conventional radiographs are considered as an initial diagnostic test. However, small stones may be missed, and only 80% of stones are radio-opaque. In such cases, computed tomography, CT, scanning, ultrasonography, and a magnetic resonance scilogram will be more sensitive for diagnosis and localization. Silography is the gold standard for diagnosis and involves injecting a dye into the duct of the salivary gland. It not only helps in the diagnosis of silolithiasis but also identifies any pathology in the duct. In addition, it may be therapeutic in certain cases. Silendoscopy provides direct visualization of the duct and can be used for the removal of stones. It is a safe procedure that can be performed under local anesthesia with better outcomes than open surgery. The smaller, less than 5 mm, distal stones can be removed with endoscopy while the larger, greater than 5 mm, distal stones may require duct slitting. For an impacted stone, the transoral route is used. Intraparenchymal stones between 5 and 7 mm can be extracted endoscopically while larger stones require transoral slitting. Stones that are not palpable and not visualized endoscopically can be removed using external shock wave lithotripsy, ESWL. However, ESWL is not suitable for stones larger than 7 to 10 mm. Hilar stones are removed using an endoscope. Excision of the submandibular gland should be considered as a last resort. Parotid stones, less than 7 mm, can be removed endoscopically, and difficult cases might need a combined transcutaneous approach. ESWL can be considered for impacted stones. Again, gland removal should be considered only as a final remedy.